So doctors, welcome. Thank you for joining us once again in the third of our four-part series. Today we're going to talk about treatment. So we talked about prevention, we've talked about diagnosis, we've covered a lot of ground, and now we're talking about treatment. So that person's gone and they've been diagnosed. What are some of the treatment options available, or the most common treatment options? Let's start from there.
Well, for the majority of women who have early stage breast cancer, so they have small tumors, they're clearly candidates for breast conservation, lumpectomy, and radiation therapy. The national guidelines are such that if a woman is a candidate for breast conservation, lumpectomy, and radiation therapy, then that is considered to be the preferred treatment, surgical treatment and adjuvant treatment, chemotherapy plus minus depending on the tumor itself. There is an increasing utilization of prophylactic mastectomy, women removing that breast and the other perfectly normal breast, and under some circumstances that is reasonable. Certainly a woman who has a BRCA mutation, or a woman who perhaps has a very strong family history of breast or ovarian cancer, doesn't have the mutation, but she knows, whatever it is, we got the genes here. So breast conservation, lumpectomy, radiation therapy, the addition of chemotherapy to prevent the cancer from metastasizing, moving to other parts of the body, targeted therapy to help control any of that metastatic disease, that is all very tried and true. It's like the lap belt in your car, okay? That's what you do. You get in, you put on your seat belt, you know, you may have the airbag, that's a good thing as well. What I'd like to do is really turn this over to Sophie, because she has some really incredible new information about a treatment option for women who are having mastectomy, which is so important to know about, that I would say, unless there's some pressing, lingering questions about lumpectomy and radiation therapy, which there shouldn't be, this is where we need to be right now with Sophie.
Great. So take us through, we'll talk a minute about the new innovation, but what's been the common treatment protocol from a plastic surgeon perspective? You know, the women that you come in, mastectomy, surgery, what has been the protocol that you've used to date? And then we'll shift gears and talk about the new innovation.
So there's really two different categories. There's the breast conservation treatment and the non-breast conservation. Meaning, are you taking out only part of the breast, or are you taking out all of the breast? And those are two different reconstructive situations. So sometimes if it's just a small portion of the breast that's taken out, you don't really need any reconstruction. Sometimes even if it's just a small portion taken out, there could be a divot or a defect or a bad scar or some deformity, and then that part has to be addressed. There are also some women who have relatively large breasts, and once a small part of one breast is taken out, it makes sense to have a breast reduction, which can be done to even them out and sort of solves a lot of those problems at the same time. So that's sort of one category. Now it gets very, very different when we talk about mastectomy, where the entire breast is removed, because now you have to recreate a breast where there no longer is one. And within that, there are two different approaches. One is to use your own tissue, and one is to use an implant. So using your own tissue, most often we use the tissue from the abdomen, from the belly, so basically the skin and fat in the belly. It's the one time in life having a big belly is very useful to you. But that's something that is done a lot, and you can get very natural results, and you don't have to use an implant. However, those surgeries are usually much longer. The recovery takes a lot longer. The scarring is much more significant, and you have to be in the hospital a longer time. And if you don't have enough of the tissue, you're not a candidate for it anyway. One of the reasons why people have been very emphatic about doing your own tissue reconstruction is because we were still struggling to get really great results from the implants. And the truth is, if we could get fantastic results every time with an implant reconstruction, we'd probably be a lot less likely to add a 4, 5, 6 hour surgery to this patient, and 5-day stay in the hospital versus 1 to 2, and several months recovery. It's a lot more work. It's a lot more effort. We'd be a lot less likely to push that, I think, if the implant reconstructions were consistently very successful. So that brings us to the implant reconstruction. So traditionally, the way that it works is, you take the breast out. So the layers are, you have the skin, the breast, and then you have the muscle, the pec muscle on the chest, and then you have the ribs, and that's where you are. So when you take the breast out, it's really just skin and then the muscle underneath. And the muscle is tight to the chest wall, and it's flat, and there's no room under it. You can't just put an implant between muscle and skin. It's not enough coverage, and it's not enough blood supply to the skin. There's a lot of sort of technical reasons why it usually doesn't work out well. And especially if a patient's going to have radiation, which also damages skin more, you need more protection for the implant. So what we've traditionally done is lift up the muscle. There's different muscles on the chest wall we use, and we put an empty implant, which is called a tissue expander, underneath the muscle. And then over time, we have to slowly inflate that empty implant to stretch the muscle out, so we now have a pocket that's big enough to put an implant in. And the way that we've traditionally done tissue expansion for many, many years is with these saline expanders. So it's an empty implant shell, and it can get saline put into it. And you put it in with either nothing or just a little bit of saline in there, and then the patient has to come to the office every week or 2 weeks, and there's a little port that you can access to put more saline in, which you find with a magnet. But you have to take a needle and stick it through the skin and through the muscle into that port, and very often the patient can feel that. And then you push the fluid in, the saline in, as much as the patient can tolerate per session, and you're always trying to do as much as you can because that's your one chance. So the patient comes back over and over and over, gets stuck each time, and each time you stick with a needle, the expander is at risk. What if you stick in the wrong direction and pop it? Or what if you just introduce bacteria and get an infection? So you have to be very careful. It's really like a procedure in the office. It takes time. It takes a lot of traveling. It's emotionally stressful. They have to take part of their day off now. And then they know that night and the next day they're going to be uncomfortable because now they've been expanded. So there's pressure on their chest, pressure when they're sleeping. It takes a couple days to settle out. What ultimately ends up happening is, even if you can put a lot in at the beginning per session, it slows down. The tighter it gets, the less you can put. So as you're getting to the finish line, you're actually slowing down. Mm-hmm. And on average, and that can be very discouraging. So the patient feels no control over the situation. They take a half a day off, they bring a relative, they come to the office, they're getting poked again. Now, if they can't tolerate as much, they feel like they failed. Then they go home and they're still uncomfortable. And now they're like, oh, it's going to be still not, I still have to go back. We still haven't gotten there. This can go on for 4 or 5 months. You can't put in the request for the second surgery because you don't know when you'll be done. You can't give the patient an answer of when they'll be done because it could be anywhere from 3 months to 6 months depending on the patient, which is also very discouraging. They're kind of in limbo. And then when you're finally expanded, you go back and you switch out the expander for the permanent implant. But this is a long process. Yeah. So that's what we have traditionally done. There is a new device, which
now let me stop you there,
yes.
Because I have to ask,
yeah.
for a man
mm-hmm.
that has had a mastectomy,
mm-hmm.
is the process the same?
It's usually not the same because, men, most of what makes up their pec is the muscle and not the breast. Men don't have a lot of breast tissue. I think for the most part, men who get a mastectomy do not elect to have reconstruction. There would be options for them if they wanted to. The implants that a man would put in are very different than those that a woman would put in, and they probably wouldn't need a significant amount of expansion because you're not trying to make a breast. So the expander situation is not really as relevant in the case of the male reconstruction. Yeah.
So the air expander
yes.
that we want
now
to
this
talk
is the
about.
innovation we're going to talk
yeah.
about. This is the new...
Yes. So
yeah.
it's called the Aeroform. It's AEROFORM. And this is a new tissue expander, which is air-based as opposed to saline-based. So it was developed by a NASA engineer and a tissue engineer, and it has space-age technology, literally. it has a little CO2 cartridge embedded inside the expander. And it's controlled by a remote control that does not need any needle or any introduction or any sticking. And it basically releases the gas, which then inflates in small increments. So the patient controls the expansion. The surgeon can also control it and can do it at a little faster rate, but the patient has the ability to self-expand in small amounts every day whenever they feel ready for it. And it locks them out so they can't overdo it, because you can't take air out of it, you can only go one way, but it goes in very small amounts. So the patient can expand 3 times a day a little bit, and if they don't feel up to it, they can skip one. But if you're talking about the numbers involved, on average you're trying to get, we talk in cc's or milliliters, so just to give you a sense. On average you're looking at about 500 or 600 cc's for the full expansion. Whether it's fluid or air, it's a quantity of volume, so it's the same amount whether it's fluid or air. So if you can do maybe 100 at a time at the beginning with the saline, you're ending up where you can only do 50 usually by the end. So you're looking at about 8, 9 expansions, something like that, and at most you can do them every couple of weeks, and then you have to wait a month or 2 for things to consolidate. That's how you get to 4, 5, 6 months. When you have the air expander, if you can do 10 cc's at a time 3 times a day, that's 30 cc's a day, which is 300 cc's in 10 days. You're halfway there in 10 days. You're halfway there in a week and a half. And then you are all the way there in 20 days. So you're looking at about 3 weeks instead of 5 months for the full expansion. There's no needle stick, so you don't risk exposing the implant. There's no needle stick, so you don't risk puncturing the expander. You have a remote control, so the patient does it at home. She doesn't have to keep coming into the office. If she does come into the office and she feels she can handle it, the surgeon has a little key that you can use to expand a little bit more, and you can put more in at a time. But otherwise, your patient can go home, recover at home, and because it's small amounts, they don't feel that sudden shock of the 100 cc's coming in at once. They can also back down if they want to and not do one that day if they don't feel like it. And it's very empowering. I think one of the most important things to it, even beyond how great the science is, how great the faster expansion is that you can feel very much like a victim, I think, when you go through something like this. It's happening to you, and you have no control over it, and there's nothing you can do about it. Now, you literally have the remote control to your reconstruction in your own hand, in your own control. And you can decide what time of day it feels right, how many times you want to do it. You feel like you're achieving something. The thing even sings to you. It has a very happy little song when you successfully expand, which feels like an achievement, as opposed to, I can't take any more saline today. Now I've just failed, and I feel like I'm not doing what I should be doing. And it just makes the whole experience completely different. And because you know you're going to be expanded in 3 weeks, you can book the second surgery right away. So you can say to the patient, even if you go slow, you'll be done within a month. So we can schedule your second surgery in 5 or 6 weeks. They have a plan. They have an endpoint. They know as of then I'll be done. It's not this empty road to nowhere where I'm getting poked and I just never know when this is going to end, which I think psychologically is incredibly important. And then the next part of it is, even beyond all of those things, the expansion itself is different. Because it's gradual and it works at just the rate that the skin needs it to work for the skin to respond, instead of ending up with this stretched out but thickened and scarred tissue that's really hard to loosen and really hard to work with and really hard to make look natural, which we said was the main challenge with an implant reconstruction, you have skin that has responded every step of the way. It's more soft, it's more supple, and you end up getting a skin quality that you normally wouldn't get from an expansion. And now you can get a little bit of that soft hanging that you want with a natural looking breast. It completely transforms the reconstruction itself. So the outcome, the experience is better, but the outcome is also better. So all the way around, you just have a completely different level of what you can give to the patients. And then if you add to that, which we can talk about if you want to, this new saline implant, the permanent implant that's on the market, which takes silicone out of the equation, so there's a lot less monitoring or concern for silent rupture. but is such a better type of implant than a single lumen saline implant. You get a more natural look, a more natural feel, and without any of the maintenance of silicone. I think if you look at these devices, this is what technology is for. There's a lot of, especially in, I do cosmetic medicine as well, there's a lot of technology that might not necessarily represent really where we want to go, but I think in this respect, this is what technology is about. This is sort of one of those times where you say, thank goodness there's technology in medicine, because this is really the next wave, and I think this is what we should be doing for these patients.
As you were talking about this, I was thinking exactly that, in a situation where as a patient you feel like you have no control, now having the ability to do this on your own and you feel an achievement must really help patients psychologically.
Yeah.
But so correct me if I'm wrong, it's my understanding that with mastectomies, there's maybe different layers, levels of a mastectomy you can do. Some are full breast removals and some you may have to remove some of the chest wall. Is that correct?
Well, let me just first comment on this wonderful, thorough, apt description of this new technology. I would summarize by saying one small step for man.
And I'll second that, by the way.
Yeah.
Or women.
Yeah.
About every 5 years in my brief life as a breast cancer surgeon, there is an innovation that changes the game. The first one that I experienced, that we all experienced, was the implementation of breast conservation versus mandatory mastectomy for everyone. Okay, now we were saving lives and saving breasts. The next one was the use of anti-estrogens. So initially it was tamoxifen, and then that was replaced with aromatase inhibitors, which were very useful and improved survival by 30%. Then we hit targeted therapy with Herceptin. So women whose tumors were HER2 positive, who were given Herceptin, had amazing results. There was sentinel node biopsy. You used to have all the lymph nodes removed. The more you removed, the bigger the surgeon you were. If you could come out of the operating room with 30 lymph nodes, you were like Napoleon coming out of Russia, victorious. It turns out you don't need to have all those lymph nodes removed. You really only need 1 or 2. That was sentinel node biopsy. This, I believe, is the next great thing when it comes to breast cancer treatment. You can remove the breast if that's appropriate, if that's your choice after a considered opinion, and you can have a reconstruction which gives you autonomy and authority, a quick recovery, and the endpoint which you can see on the horizon very quickly. Now, when it comes to mastectomy, you can remove the breast to a greater or lesser extent. Back in the day, there were pioneers at Johns Hopkins and at Memorial Sloan Kettering, where I did my training, and they would remove everything from the sternum, to the back, and Urban actually went up into the neck. And it was a scorched earth policy. They just took everything. They took the breast, the skin, the muscles, everything. And then Urban, as I say, went into the neck and took the lymph nodes in the neck. And they got no better results. The women were not living a day longer than the women who just had lumpectomy, and so the women said, you can forget that. And then the physicians looked and said, well, we really don't need to do this. Let's just remove the breast and all the lymph nodes, because removing those lymph nodes back in the day helped to determine whether you needed chemotherapy, how much chemotherapy, what chemotherapy. So if you didn't have any lymph nodes involved, let's say you had 30 removed, none of the lymph nodes, okay, you didn't need chemotherapy. You had 4 to 3 to 5, whatever, you needed mild chemotherapy. You had 6 to 10 nodes, oh, we're going to give you adriamycin. You're going to lose your hair, you'll be sick, it's worth it. Over 10, bone marrow transplant. We were able to replace all that by just looking at the tumors and not the lymph nodes, introduction of sentinel lymph node biopsy. So we're no longer going through the axilla like Grant went through Richmond, 1 or 2 lymph nodes, and you only need to remove the breast tissue itself. You don't need to take those muscles. You certainly don't need to be in the neck. And so there's a movement, and I think it's appropriate, and I'm a surgeon, but it's appropriate to do only the surgery that you need. And it turns out You don't need a whole lot of surgery. Get around the tumor, have negative margins, which means if they take out the tumor, there aren't any cancer cells around the edge. That's complete excision, the margins are negative, good, you're done. Then you get your radiation therapy, and if you need treatment besides that, chemotherapy, targeted therapy, whatever, then you get that.
So the innovation, going back to that, again, the device, it's air. Now you're setting the volume. The physician is setting the volume on how much can be put in?
No, so it's already pre-programmed that if the key is not in there to unlock it, it can give you 10 cc's a day, 3 times a day. So you can get
Regardless
up
of
to,
how large or small you are.
right, that's what the patient can give herself.
Got it.
Which prevents her from overexpanding, because otherwise if she put too much by accident, you can't backtrack.
Yeah.
But the surgeon has a key. So if she comes to the office, you can put the key in, and you can dose as many times as you want if you want to kind of jump start because you feel like there's enough room and she's comfortable.
Yeah.
So you can go faster, the surgeon can go faster, but the patient is very controlled so that they can't overdose themselves.
And putting this implant in easier than the old way?
So the only thing about it that's different is because of the CO2 cartridge, it starts out a little bigger than just the empty water balloon. So you need a teeny bit more room, but it's by no means a game-changing amount of room. It doesn't make the surgery more difficult or more extensive. You just make a little bit more space, and it's really otherwise inconsequential.
Got it.
Yeah.
So a little earlier we were talking about prophylactic mastectomies, and there are some women who are at high risk and they decide to undergo the prophylactic mastectomy. We've seen a lot of women in the media doing this, but for younger women who are at high risk and don't necessarily want to go through the prophylactic mastectomies, for instance, maybe you haven't had children yet and you would like to involve breastfeeding in your child rearing, are there any non-surgical options available to lower one's risk if they are predisposed already?
Well, there are ways to lower the risk. That's, I think, a different discussion from are there any other options. So you are told, you know, you've got a breast cancer or you've got the gene. Your sister had breast cancer at the age of 28. She's BRCA positive. You get tested, you're BRCA positive. But you're 26 and you haven't had children yet, and what are you going to do? Because what's on the table is remove both breasts, remove both ovaries, because the risk is for ovarian cancer. And breast cancer may not kill you, but ovarian cancer probably will. Are there any other choices? It turns out there is a choice. Having both breasts removed will lower the risk of you having breast cancer in that chest wall, in those scars, reconstructed or not, by 95%. So even if you have both breasts removed, you still have some real breast tissue around there. You could have a tumor that grows in that residual tumor site. But what you could do is you could have a mammogram once a year. And so you've got your mammogram every 12 months. And 6 months later, you could have a breast MRI, and you could have that once a year. So now you're staggering. Every 6 months, you're having a diagnostic study. Even if you're young, you got dense breasts, okay, you can have, you know, your ultrasound as well. But every 6 months, you're having a diagnostic study. And if, God forbid, you were to develop a tumor, you're going to find it early. It's going to be treatable. The verdict is in. You got the breast. You have the gene. You got the breast cancer. Off come the breasts. Okay. The difference in survival, it turns out, between having both breasts removed today, when the test comes in and you're BRCA positive, versus I'm going to go for the mammogram and the MRI at 6-month intervals, is about 3%. It's about a 3% difference in survival. And this is 5-year survival, given the diagnosis. So this is negotiable, I think. Again, you need to really look at the family history. If you've got 2 people with ovarian and 3 people with breast, you might say, But if you've got one person, first-degree relative, with a BRCA mutation and you want to have your children, you may think, okay, let me go this route, there's a 3% difference. I know I'm being followed very closely. They're going to be right on it. And if it happens, we're there and I get treated. Again, recall that women who carry a BRCA mutation have a 50% risk of getting the breast cancer by the time they're 50. So there's a window of opportunity. And then in addition, there are physicians like myself, and certainly the 1/3 of patients in my practice that are high risk. There are other interventions. There are foods you can eat that reduce the impact of the breast cancer virus. There's exercise. There's like no alcohol, no birth control pills, and nothing, no smoking. There are all kinds of things that you can do so that you really maximize that X factor in the equation. You get that down to 0 as much as possible.
So Dr. Sophie, the name of the innovation again?
Aeroform.
Aeroforms.
AEROFORM. The Aeroform expander.
Yeah. What an innovation and a game changer.
Yes.
Yeah, absolutely.
Yeah. Well, thanks for coming in, and I look forward to our next discussion.
I as well. Thank you.
Thank you.